Hey, I'm Sarah Smith, family doctor, clinical day advisor, and the chatting coach. Welcome back to Sustainable Clinical Medicine podcast, where we're going to be interviewing peers or world experts who can help us think about our clinical day in a way that is more sustainable and create time for our lives outside of medicine. Hey listeners, I value you being here. Please, I encourage you to leave a review. I'm going to be reading out a review each month, and that person can have a one-on-one call with me to have a chat. And I think that is a great way to reward you as a listener. Also, as you like and subscribe to this podcast, it helps get our message out to other physicians and clinicians who are struggling. Thank you so much for your reviews, and I look forward to reading them out here on the podcast. Welcome back, everybody. Today we have with us Stefanie Simmons. I'm so excited to meet with you and talk to you. I'm going to let you introduce yourself. Welcome.
Thank you, Sarah. Hello, everyone. My name is Stefanie Simmons. I'm an emergency medicine physician by training, and I am the Chief Medical Officer of the Dr. Lorna Breen Heroes Foundation. So as the Chief Medical Officer, I help to design our programming. I'm one of the 3 executive leaders of the organization, and we are doing our best to help combat healthcare workforce burnout.
Oh, I love that mission. That sounds really important, especially in a lot of emergency medicine, but also all of us in medicine. Can you tell us how you got into this area?
Yeah, sure. So I'm going to have to take you in the way back machine a little ways, really back to residency. I was not somebody who grew up knowing that they wanted to be a physician. I came to it very late. In fact, I applied to medical school, epidemiology, genetic counseling, all at the same time, and sort of let fate sort me. And it did into medicine. And I thought I wanted to be a family medicine doctor when I started, but I loved procedures. I loved resuscitation. I loved caring for patients from birth to death and in pregnancy. And so because of all of that, I decided to be an anesthesiologist. And I matched into anesthesiology and was very excited to start that residency program. And it was during that first year that I switched into emergency medicine because I had a rotation in the ER that made me realize all of the things I loved about anesthesiology existed in the ER too. But it's sort of this wacky, wonderful environment where all of the most interesting humans end up, congregating, either because of their experiences of the day, they're in this raw sort of state, or because of their choices. And so I love the emergency department. I loved being a resident. But I was in a sort of a hard place at the end of residency. So I had 2 children during residency. It was quite a successful resident. I was performing very well. I had successfully competed for a prestigious fellowship, research fellowship. And I developed sort of peripartum depression during my last year of training. And because I was about to get my first job and about to get my first official license, I decided to not get help because I knew I was going to be asked if I had a mental health condition. I was going to be asked if I had been to counseling or therapy as part of that licensing and credentialing intake. And I was worried that it would have a negative impact on my career if I was answering yes. So I had a rockier end of residency and first few years out than I needed to because of that. But I was preparing grants. I was teaching residents. I was working clinically. I ended up not pursuing that fellowship. And because of the work I had been doing in quality and safety, I was asked to be the quality and safety director for my medical group about 3 years out of residency. And I said, no, thank you. I think you can find somebody to do that role. That's not me, but you need somebody to be looking after the healthcare workers and the patients here. And they said, well, we don't have that job. And why don't you write up a job description and see how it turns out? And so I did. And I was given that role and grew it over years. As my group was acquired and then merged with other groups, I continued to do that work for larger and larger numbers of first emergency physicians and then emergency and hospital physicians, and then ultimately emergency hospital anesthesiology, women's and children's surgery, and really looking after the well-being of 26,000 physicians and physician assistants and nurse practitioners. So that is what I was doing at the beginning of the pandemic. And that is when the foundation came about. And that is why we were connected in doing this work together.
Yeah, okay. That is a big ask to start something new for a whole lot of really important physicians, healthcare workers, patients, well-being work. So I understand why you wanted to start this work. How did you go about it? What were the things that you were wanting to do differently? How did you start pursuing that change?
So it's a great question, and I will answer the question. And I think it's important to put us into a time here
Yeah,
because this is about 15, 16 years
yeah,
ago.
yeah.
So there were fewer resources,
Mm-hmm.
in the mid to late aughts, than there are now. And so what I did, I would not recommend people to do today because there are
Yep.
so many better resources and ways to go about it. Um, a few things. The first thing was that I reached out to healthcare workers, so the doctors, the physician assistants, and the NPs who worked in our group who were receiving patient complaints
Mm-hmm.
or team complaints and offered to coach them.
Mm-hmm.
Now, I was not a coach.
Mm-hmm.
I did not have a coach training.
Mm-hmm.
I do now. I did not
Mm-hmm.
then. But I knew that there was something there that was about, the behavior was about knowledge, but there was also something else. And so as I was coaching one-on-one clinicians who were having these communication difficulties, I started talking to them, right? And it became very clear that if you scratch a communication problem,
Yeah.
right, with a clinician, there's a personal
Yeah.
mismatch, either with the
Mm-hmm.
mission of the work or the work environment or the
Mm-hmm.
resources that are being given or the
Yeah.
well-being of that clinician. And so um, the work around patient experience rapidly transitioned to work that was primarily around healthcare worker experience.
Yeah.
And in addition to that intensive coaching, we also launched a program where people could observe and give feedback to each other on their communication skills, which actually ended up being a co-mentorship opportunity.
Yeah.
And to have these conversations about, oh, you have that conversation that way. I actually have that conversation a different way. Let's talk. And
Yeah.
many different relationships sort of around the medical practice sprung up from that. We also did work on leadership development and training our leaders. And as time progressed, then built in additional resources. So one of the recognitions early on was that when there's an adverse event, when there's a patient death, or when there's harm, or when heaven forbid there's a lawsuit, healthcare workers need additional support. So thinking of the second victim syndrome, right? Of the person who you are dedicated to caring for is harmed, and you actually incur a harm from that as well. So supporting people again through one-on-one coaching and additional support in the cases of adverse events and lawsuits. That transitioned and merged to providing access to mental health care.
Mm-hmm.
And then the beginnings of advocacy around credentialing reform. So in the US, when you start working at a hospital or health system, you're credentialed, probably the same in a lot of different places. It's separate from your license at the workplace process. And just like on the licensing forms, there can be questions about a past history of mental health care or diagnosis. Those questions can exist on the credentialing form as well. So right around the time the pandemic started, I had begun that advocacy journey at the organizational level to question whether that approach was A, helping keep patients safe, B, helping to keep clinicians safe, or C, like based in any evidence whatsoever. And so it was at that moment that sort of the pandemic started, the foundation started, and that's the work I was doing at the time.
Yeah, so good. Such interesting questions to ask of the organization. Did you answer that question? Was there what was the idea behind these questions, and has it progressed to a better place now?
Great question. So for licensing organizations in the US, those are based on the state. So each of the 50 states has a different licensing organization. Their goal is to ensure the safety of patients, right? Community safety. And so there is a thought that if we are flagging people who may be impaired from the safe practice of medicine or nursing or pharmacy, of dentistry, that we could then look into their background a little bit more and make sure that they're safe. The problem comes in flagging the diagnosis or treatment of a mental health condition as one of those predictive factors, right? Because there are many reasons why a healthcare worker can be less safe for providing care. There are physical reasons, right? There are substance use reasons, there are social reasons, etc. But the diagnosis and treatment of a mental health condition by itself is not necessarily predictive. And in fact, since we know that healthcare workers develop a mental health condition or a substance use disorder at the same rate or more than the background population, if you're doing anything to deter people from receiving care, you may actually be causing patient harm by allowing people's mental health conditions or substance use disorders to progress to impairment without treatment. So I'm going to give a comparison to a medical disease to show how silly this sounds, right?
Yeah.
So what if on the application we said, have you ever had your blood sugar checked or had it found to be elevated? Okay. And we're asking that because if you develop acute diabetes, you may have a hypo or hyperglycemic event while you're taking care of patients and cause patient harm. And if you do say that you've ever had your blood sugar checked or been diagnosed with diabetes, we're going to flag your license application, flag your credentials. They may be delayed. They may not go forward. The process is not transparent. We won't tell you what we're going to do with that information or what happens. What we would see and what we do see with mental health care is that healthcare workers all of a sudden are not going to get their blood sugar screened. They don't want to have their hemoglobin A1C checked because they're going to have that flagged on their application and potentially have a delay in their professional processes. And so all of a sudden we'll see healthcare workers who have diabetes and are developing hypo or hyperglycemia on shift, right? And causing altered mental status. So that's the same flawed logical process that we're seeing with mental health care, except in addition, there is external stigma about how we talk about mental health care that is additive, even more so. People don't think that because you have diabetes, it's a moral failing.
Yeah.
Although when you start to talk about type 2 diabetes and body weight, some people feel that way, right? But that is still it's a minority but pervasive idea about mental health care. And so it's even more important to destigmatize the institutional language.
Yeah. Love it.
You
Love
caught me
it.
monologuing, Sarah. That's something
No, very
I can
good.
talk about a lot. Yeah.
No, this is very good. Now, I want to ask about initially when you were seeing the physicians who were flagged with a communication issue, and I think that was a reasonable place to start, of course, because why not start with the people who may have external ideas that they're not doing as well, right?
Mm-hmm.
I noticed that you talked to them one-on-one, and it was a peer, and it was about connection. Like there was a connection there. Was it protected? Like, was there going to be the potential for someone to look at those conversations? Was there notes taken? Like, how did you create a safe place for them to come and chat to you?
Yeah, it's a great question. And we did have also, as that program grew, formal peer support, and also so formal peer support, and then also formal coaching. And we ended up with a whole team of coaches. So important questions. The peer support, when there had been an adverse patient outcome, or if there was litigation, was sort of filed under um, quality improvement and quality assurance review, right? So we wanted to make sure that those conversations did have protection. So if there was an actual claim, right, that peer supporter was working through the attorney who had been assigned. And so the conversations were sort of part of the litigation process for that clinician and had some protection. Uh, this is tricky because there are different laws in different states and in different countries about which conversations are protected, right? And one of the things the foundation advocates for is universal protections for the discoverability of peer support conversations, because we want people to be able to reach out, say they experienced a patient death, right? And every physician who's ever practiced has had an adverse patient outcome. And invariably, we have feelings about that. And it's very helpful to be able to reach out to a peer and to say, I had a really hard case. Here's what happened.
Mhm.
I can't get over blaming myself for what happened,
Mhm.
right? Without being afraid that your peer is going to be subpoenaed to testify at the litigation proceedings and have to say, yes, my colleague feels responsible for what happened, right? It's not an admission of guilt to say that
Mhm.
you feel bad. And so there's, there are some ways to protect that speech. In terms of coaching where there wasn't an adverse event or it wasn't sort of litigation involvement, in that case, this was much more of a functional coaching. So behavior based. What's happening? Why is it happening? What do you think would be helpful? And then the outcome then is sort of that plan that's co-developed on how things are going to get better. But what the coaches were able to do is to advocate for things like scheduling shifts or, um, you know, or time for the clinician to start their shift that would be more integrated into their work life. And I could give you an example. So we had a clinician, and I'm going to change some of the details here, but who was referred to coaching because they were showing up late for shifts, they were grumpy with the nurses, nippy, I think was the actual words, right? And this was at a hospital that was particularly hard to staff. There was no problems with the clinical care, but just like, we're not sure this person's going to work out at this site. Can you come in? So I started by just observing on shift and watching, and then had the conversation with the doc. Well, in the course of the conversation, it turned out um, his child had been diagnosed with lymphoma. The reason he was late is that from the end of her infusion appointments to the beginning of his shift time was like 15 minutes.
Mm,
And it was just enough time to like drop her at the doorstep and then get
mhm,
to shift a minute early.
mhm.
But who's going to drop their teenage child with lymphoma at the doorstep and say, get yourself settled in, sweetheart, after their chemo infusion?
Yeah,
So he
yeah,
he was late because he was caring, and he hadn't had that conversation with his leader, right?
yeah,
So then it becomes, how do you help to
yeah,
encourage and coach that person around the conversation?
yeah, yeah. Such
Yeah. And there
important
were
work.
real concrete things that could get better for them.
Yeah, such important work. And to even think that someone's going to stop themselves getting the help they need or say something because I think there's going to be a negative consequence is so heartbreaking.
Mhm. Mhm. It is, and in this case, that was the perception, but not the reality, because once we
Mm.
were able to surface that issue, like the team really rallied around this person and were able to get them through this situation in a positive way.
Oh, that's a wonderful, wonderful story. Thank you for not a good start to the story, but I'm glad that the team was able to come together. Yeah. I
Mhm.
noticed it's coaches and not psychologists. Was there a reason that
Right.
we had that as the primary people brought in?
So this was feedback around performance
Hmm.
and problem solving and
Hmm.
being a thought partner with the individual to problem solve the behavior and the work related environment issue. Many people who were coached were recommended to also have a therapist, right? Coaching is not therapy.
Yes,
Therapy is not coaching. There,
yes,
there can be some overlap, right? You are talking to someone and coming away with insights, but
yeah,
they're different. And so, as I actually went through my experience as coaching, and started to have a team of coaches, it became clear that we needed formal training, and did receive training then through the ICF certification. Yeah.
yeah, yeah. So the coaching's more about not diagnosing. It's
Right.
about looking at the person, their goals, what they're wanting to achieve and change and moving towards it, and keeping out of the diagnosis and therapy space.
Yes. All together out of that space, and really serving as a thought partner.
Hmm.
So it's really listening to what somebody's telling you, condensing that down to an insight, reflecting it back to them, and hearing, what that sparks for them. Or and then in this situation, it was also being an advocate.
Yeah. Are you seeing more of that um, being done in institutions now that there are people, coaches, peers, mentors around that are being connected to physicians so that they can offload what's happened, validate, make plans for what they want to do differently within their space, or come up with problem solving around what's not working well for them within their institution?
Mhm. So there has certainly been an explosion of the availability of coaching, um, in terms of finding and contracting with your own coach, right? So there are more and more physician peer coaches who have training and are doing this as part of their sort of their career or their overall goal. There have been some organizations that have done this on an institutional level, but it is by no means universal or common, and is really a an example of a mature organization when coaching is being offered for strategic career development.
Yeah, yeah. Okay, beautiful. What about now when a physician's going through a hard time, are they now more likely to want to or feel confident seeing a psychologist? Have we got to a point that it feels safer to do so?
Well, a few thoughts on that. So first of all, I think that, 5 years ago, almost exactly, when we were in the first year of the global pandemic, the conversation around mental health shifted.
Hmm.
And I used to say, like, if you aren't feeling anxious, you're not paying attention, right? Like, there was a global anxiety, and I think also a recognition that not only were we experiencing a shared traumatic experience, but that our healthcare workforce were exposed to specific traumas.
Mm.
Um, and it opened the door, I think, to a lot of people as to what our workforce goes through. Now, that six months earlier, the National Academies of Medicine in the United States had published a consensus statement on the importance of professional well-being. So this wasn't a problem that started with the
Mm.
pandemic, but it did open a window
Yeah.
for the conversation in a different way than we had seen previously. Around that same time, in the subsequent years, the Surgeon General in the United States issued an advisory on professional well-being. You started to see recommendations around professional well-being programs. The Impact Well-being Guide was published by the CDC, which was a guide for healthcare leaders on how to improve the environment of care. And this work of eliminating these invasive and stigmatizing questions around mental health started to accelerate. So the work really started in like 2017, 2018 in the US. There was a white paper published by the Federation of State Medical Boards recommending that that question not be asked. Um, and then after 2020, with the work of the Dr. Lorna Breen Heroes Foundation, um, and many other organizations that partnered with us to say, we think these questions are also a bad idea. Please don't ask them because you think we are asking you to, right? So the accreditors, the professional organizations, et cetera, said, it's not us. Please consider changing these. And so we went from, in 2022, 17 states being consistent with best practices for the state physician licensing to 38 states being consistent with best practices. So that almost a doubling, and being able to certify more than 10% of the hospitals and health systems in the country as being consistent with best practices. So in order to do this, we have a badge, the Champions Challenge badge. We actually review the applications for any organization or state that we give the badge to, and then we publish a map. Now, it's a map of the United States because that's where we're doing our work, but in the US, we've been able to see a change in how these questions are being asked and where they're being asked. And since we know that that is one of the uh, key reasons why healthcare workers avoid mental health care, we are starting to see evidence come in that the tides are changing a bit. So there's been a shift in external stigma from society. There's
Yeah.
been some people sharing their stories and a shift in the culture of medicine. And then some of the real institutional stigma is starting to change as well.
That's such good news. Thank you. So good.
Still,
Um,
still a lot to do. Still
oh,
a lot to do.
100%. Are you hearing back from physicians about the environment that they're working in and the We hear that healthcare is broken, the system doesn't look after me or the patient, and the whole thing is still contributing to that traumatization, wounds, not doing well within the institutions that they're working. Are you still hearing that? Is there progress that you're seeing? And I know you're not working in that area specifically, but any comments in that area?
Oh, we are working in that area actually. So what we've been talking about mostly up until now has been individual support,
Yeah,
removing the barriers to mental health access.
yeah.
But we are also like, we recognize that in addition to individual support, like the systems need to change. So, I mean, one way to put this is don't just try to build a stronger canary, right? Like build a better coal mine. Make sure that people can work in systems that work for them and work for their patients. So really human-centered
Mm,
systems of care. And we've got a long way to go, Sarah, to have a truly human-centered systems of care. And I don't think that's just the US. I think it's healthcare everywhere, right? So recognizing that this is a deeply human interaction between a patient and a healer.
mm.
And I can't remember the last time I heard a physician or a nurse or a dentist or a pharmacist called a healer. But that's what we're trying to do is diagnose and heal disease and to relieve suffering. And when you're in a system that is transactional, it doesn't leave a lot of room for healing. And when you are spending your time documenting every detail so that you can bill, so that the care can be reimbursed, so that the hospital stays open, right? Those we recognize like those are important steps because we need hospitals that are open, but it doesn't leave a lot of room for the human interaction of healing. And that is usually why people have gone into healthcare is because of those human interactions and the opportunity to use their talents to make a difference in somebody else's life. So if you feel like you don't have the opportunity to do that in your work, um, that's a huge dissatisfier. And we know that administrative burden is one of the largest contributors of burnout to physicians. So one of the things we are doing is working in geographic coalitions by state and working with the professional societies for the doctors and nurses in the hospitals. We do the licensing and credentialing work with them first, then leadership education around a systems approach to professional well-being, and then a learning collaborative so that they can change the work environment. Our first learning collaborative, so this is a 3-year journey. Our
Yeah,
first learning collaborative is wrapping up this fall,
yeah.
and they all focused on the electronic health record
Mm,
and how to optimize the clinician experience of charting, whether
mm,
that was with ambient documentation or generative inbox message generation or reducing interruptions. Uh, these organizations made progress and they didn't measure that progress by how many clicks they reduced, right? Or the efficiency and the number of patients seen in a day solely. They measured it in clinician experience, healthcare worker burnout, time charting away from work. So did you have to bring your computer home to finish your
mm,
charts or could you get it done at work, right?
mm.
So really building in human-centered measurements to the assessment of the project.
Okay, then that makes my heart happy because we know that the um, EMR is not designed for the clinician. It's not a tool that made our lives easier for the most part. It was an administrative tool for others. That's wonderful. Where do is there going to be a paper on that? Will it be available? How do organizations find out more about what you're doing and get enrolled in this?
So I would encourage anyone interested in learning more about the work of the foundation to visit our website. And if you have show notes, we're happy to send you some links for that. The ways that organizations can partner with us right now is if they're part of our state coalition. So this is philanthropically supported work that we do on a state level. We also work with individual organizations with strategic planning around their professional well-being work. And we do that based around an organizational maturity model called the Breen Scale, looking at where the organization falls along different categories of organizational dynamics in terms of early advancing or maturing um, professional well-being work. So there are many ways to partner with us, and the simplest is to access our toolkit and change the credentialing application and get a badge so that we can recognize the work of an organization.
Yeah, that's excellent. Thank you. Is there anything we didn't talk about that you wanted to share with listeners before we head off for today?
Sure. So as we talk about mental health care, there's a resource through the foundation called All In for Mental Health. It emphasizes 6 actions that organizations, governments, individuals can take to help increase mental health access for healthcare workers. So that includes some of the things we've touched in today, including privacy for peer support, privacy for mental health care for healthcare workers, and access to additional education and training around professional well-being throughout sort of professional training and beyond.
Yeah, wonderful. That sounds really important. So I think we encourage you all to go and check that out because we all as health workers need to make sure our mental health is looked after because we are being harmed within the work that we're doing because we're working with people and people not at
Well,
their
we're
best.
working with people. Yeah, we're
And
working with people who are having the worst day of their lives often, right? And
yeah,
witnessing that human suffering and suffering alongside them often as we do our best to heal.
yeah. And within institutions that we often don't have immediate control over as well.
Mhm.
Yeah,
That's
yeah.
right.
Thank you so much for this conversation, Steph. I really appreciate you being here with us today.
My pleasure. Take care.
Thanks, everyone. See you next week.
Hey, if you found this podcast episode helpful, I would encourage you to like and subscribe. Every time you do, you help a colleague or friend find our podcast and it can help them too. Don't forget to share it along with your friends. If you're looking for extra help, don't forget we have charting champions for physicians and smarter charting for nurse practitioners and other clinicians to help you get home with your work done. We are helping you create sustainable clinical medicine. Thanks for listening.